Hello, this is Jacqueline Muniz, RN and DNP student at Palm Beach Atlantic University, presenting a case study on ventricular septal defects as it pertains to our recent study of cardiovascular diseases. The overview of this case study is as follows. A 2-month-old boy was brought for evaluation of poor feeding and rapid breathing. Pregnancy and a home delivery were uncomplicated. In recent weeks, the mother had noted that the infant tended to sweat during feedings. At other times, his breathing seemed fast and he was fussy. Physical examination showed a well-developed, irritable infant with a pulse of 160 beats per minute and a respiratory rate of 72 breaths per minute. His skin and mucous membranes were pink. The precordium was hyperdynamic with systolic and diastolic murmurs. The liver was slightly enlarged. Biventricular hypertrophy was evident from the ECG. Echocardiography showed a large muscular ventricular septal defect with dilation of the left atrium and left ventricle. Cardiac catheterization showed moderate pulmonary hypertension with normal pulmonary vascular resistance. The infant was treated with digoxin and a diuretic, and his symptoms gradually resolved. Later, a palliative surgery was performed, and the patient did well postoperatively. Described by Kumar, Abbas, and Astor, ventricular septal defects, VSDs, are incomplete closures of the ventricular septum, allowing free communication of blood between the left to right ventricles. They are the most common form of congenital heart disease. VSDs are classified by size and location. About 90% occur in the region of the membranous intraventricular septum. This is known as membranous VSD. The remainder occur below the pulmonary valve, known as infundibular VSD, or within the muscular septum. VSDs can be single or multiple. As far as clinical features, most VSDs manifest in the pediatric age group, as seen in this case study, and are associated with other congenital anomalies, but can be isolated. Size and whether there are associated right-sided malformations determine functional consequences of VSD. In this case study, the 2-month-old boy presents with a large muscular ventricular septal defect. Large VSDs tend to cause difficulties from birth. This includes significant left-to-right shunting, leading to early right ventricular hypertrophy and pulmonary hypertension, both evident from ECG and cardiac catheterization. If large VSDs are left unclosed, it can lead to irreversible pulmonary vascular disease resulting in shunt reversal, cyanosis, and death. Although the pathogenesis of congenital heart disease remains unclear, it is presumed to result from abnormal cardiac vascular development caused by the interaction of genes in the environment. Research shows that the current occurrence of congenital heart disease is associated with human disease genes, which have been confirmed in the pedigree of congenital heart disease by genetic testing. In a study by Wing et al. Titled Familial Congenital Heart Disease, Data Collection and Preliminary Analysis, researchers studied family history and risk factors associated with congenital heart disease. Results of the collection and analysis of data within 25 families found that the prevalence of congenital heart disease in first-degree relatives is 43%, in twins 90%, and siblings 62.2%. 11 families were found to have the same phenotype, which included ventricular septal defect found in 6 of these families. The data from this study reveals that genetic factors play an important role in congenital heart disease. As far as clinical presentation, symptoms typically manifest between the ages of 4 and 8 weeks. Retardation of growth is a major manifestation of the increased flow of blood to the lungs. The increase in the work of breathing related to the decrease in lung compliance results in the need for increased caloric intake, which cannot be met during infancy. The increase in flow of blood to the lungs also results in decreased systemic flow, which further compromises the growth failure. The increase in pulmonary flow, and hence in pulmonary arterial size, causes obstruction in both the large and small airways. It is intrapulmonary relationships that create obstruction of the small airways, with resulting pulmonary hyperinflation. The engorgement of the pulmonary arterial circulation may cause pulmonary edema, and combined with compression of the airways, results in lower airway disease and produces the symptoms of wheezing, tachypnea, and respiratory distress. If there is associated pulmonary stenosis, however, then flow to the lungs will be decreased. Depending on the extent of the obstruction, this can result in cyanosis. In patients with large defects and low pulmonary vascular resistance, the precordium is hyperactive due to volume and pressure overload of the right ventricle. In such patients, there is a loud second heart sound with components of both aortic and pulmonary valvular closure. A murmur is also present due to increased pulmonary flow. In patients with large defects but low pulmonary resistances, the murmur is harsh and hollow systolic. A diastolic rumble heard in the mitral area in such patients due to functional mitral stenosis will confirm the presence of a large defect. As far as diagnosis, upon physical exam, auscultation of a heart murmur typically leads to further evaluation. Today, echocardiography plays the major role in diagnosis and in guiding subsequent decisions regarding disease management. The electrocardiogram may show features of either left or right ventricular hypertrophy, but often shows features of biventricular hypertrophy. In the case study, electrocardiography reveals the 2-month-old patient with biventricular hypertrophy. The chest X-ray is helpful in estimating the flow of blood to the lungs and hence the significance of the defect. Septal Doppler interrogation in the parasternal long axis view is helpful for evaluating the velocity and direction of the blood shunting across the defect. Cardiac catheterization can also be used to diagnose and delineate the anatomical and hemodynamic characteristics of the holes between the ventricles, including the degree and direction of the net shunting across the defect. As far as VSD management, as in our case study, when interventricular shunting is sufficient to prevent normal growth, producing difficulty in feeding, diaphoresis, or tachypnea, diuretics are the first line of medical palliation. Afterload reduction may also be needed to encourage direct systemic flow from the left ventricle, thereby decreasing the amount of left to right shunting through the defect. Afterload reduction is achieved using ACE inhibitors. Inotropy through digoxin is of benefit in those patients with large left-to-right shunts and volume overload of the left ventricle, although its use is increasingly coming under scrutiny. Inotropy and afterload reduction can also be achieved by giving milrinone intravenously, but such therapy is usually reserved for patients awaiting imminent surgery. In general, if a patient is symptomatic and needs palliation, it is preferable to refer for urgent surgical correction. In the case study with a 2-month-old infant, a diuretic and digoxin is prescribed for disease management before surgical intervention. Surgical or catheter-based closure is usually performed for large defects to prevent irreversible obstructive pulmonary vascular disease. Treatment of small VSDs, typically asymptomatic, is generally delayed in hope of spontaneous closure, which occurs in many cases. One study by Adamir et al. Evaluated the outcomes of patients undergoing surgical repair of isolated ventricular septal defect in the first year of life, with particular attention to age and severity of pulmonary hypertension. The results of the study showed that all mortalities were patients with severe pulmonary hypertension, aged between 3 and 12 months. The incidence of mortality was higher in patients over 3 months of age undergoing repair of isolated VSD. The data suggests early surgical repair of isolated VSDs in infants less than 3 months of age with severe pulmonary hypertension to achieve more favorable results, as was the case for the 2-month-old boy in the case study who underwent palliative surgical intervention. This concludes this case study presentation on ventricular septal defects. Thank you.